If you're a patient with a herniated disc or spinal stenosis or spondylolisthesis, and you have a clear problem, which is documented by x-rays, by CAT scans, by MRIs, and you visit a surgeon and you find out that the surgeon is very reluctant to operate on you, that can be a very frustrating experience as a patient. And I feel terrible for the patients who are in that situation. So today I want to talk about a very common frustration that patients have about their surgeon, which is, why won't my surgeon operate on me? Probably the number one reason why surgeons are reluctant to operate on certain patients is because there's a mismatch of expectations. I always tell my patients that spine surgery can make you better, and usually it does make you better, but it cannot make you perfect. We cannot guarantee that as surgeons. So for example, if you have a herniated disc and you're having terrible sciatica going down your leg, and you've done physical therapy, taken medications, you've had epidural injections, and you've given it many, many months, and you're still not better, and this has become a big problem, and you go to your surgeon and say, you know what, I want to have a discectomy surgery done. But if you're expecting that all of these problems are going to be 100% resolved with the surgery, well, unfortunately, that's not a realistic expectation. Yes, the vast majority of patients will have an excellent result, and some of them actually may be 100% better. That does happen a lot, but there's going to be a substantial percentage of patients where this problem is not 100% resolved. So you may be 95% better, you may be 85% better, you may be 98% better, or you might even be 70% better. So the higher your expectations are of a surgeon with the surgery, unfortunately, the less likely your surgeon is to offer you that surgery. Now, why is that? Why is the surgeon not willing to take that risk? I think a lot of times patients have a hard time understanding how difficult it is for a surgeon to do an operation and have a result that the patient is not happy with. This can have a lot of ramifications. And as a surgeon, you start getting a reputation that you operate on people who don't get 100% better. So no surgeon wants to have that reputation. So a lot of surgeons are very, very careful about which cases they pick and which cases they pass on. If you as a patient are stuck in this situation, you may want to get a second opinion from another surgeon. And if the second surgeon also tells you that, I can't really guarantee you a result, that means that two surgeons have told you basically the same thing, and maybe you need to adjust your expectations of surgery. I think this is a big mismatch of expectations, which unfortunately a lot of times surgeons don't communicate properly with their patients. When I counsel my patients for surgery, I always remind them that spine surgery usually will make you much, much better, but it will not make your condition perfect. A second group of patients where the surgeons are somewhat reluctant in offering a surgical treatment for their condition is in patients who have severe heart, lung, kidney, or liver problems. For example, if you have bad heart disease, if you have kidneys on the verge of dialysis, if you have a bad liver, well, you can have a lot of complications after surgery. You can have a heart attack, you can have coagulation problems, you can have bleeding problems, your kidneys can fail completely, and you could actually need dialysis after surgery. So for all of these reasons, surgeons are very reluctant to operate on patients who are in poor medical condition. And this is a terrible situation as a patient because you're stuck between a rock and a hard place. But at the same time, as a patient, you have to understand that the surgeon does not want you to get a complication which can be life-threatening and life-altering. A third group of patients where there's a clear surgical indication, for example, there's a huge herniated disc, there's severe spinal stenosis, but the surgeon is very reluctant to operate, is those patients who have uncontrolled diabetes. Now, if you have diabetes and that is not well managed, not well controlled, and you have a spine surgery, your chances of getting complications like infections, like non-healing of tissues, and just a poor overall outcome are very, very high. Now, if you have a spine problem and you need to have a surgery, you have to get your diabetes under excellent control. And once your hemoglobin A1C is as low as it possibly can get, then your surgeon is much more likely to offer you an operation because your surgeon wants you to get better. They don't want to do a technically well-executed surgery and later on end up with an infected wound and a life-threatening complication like a sepsis. A third group of patients on whom surgeons are very unlikely to operate on are smokers. Smoking has many negative effects on the body in general and the spine in particular. There have been many studies which have clearly demonstrated that patients who smoke and who end up with a spine surgery in general tend not to do very well after surgery. They have a lot of complications like infections, wound healing problems. The screws and the rods in the spine can sometimes become loose. The bones don't heal properly, and they in general tend to have higher pain scores and much higher levels of dissatisfaction with surgery. So if you're a smoker and you talk to your surgeon will do their very best to get you to quit smoking, to get you to quit all forms of nicotine before they offer you a surgical treatment. Patients who are on blood thinners for medical reasons are also much less likely to be offered surgery by surgeons. Why is that? So, for example, if you have a history of strokes or heart attacks and you have a blood thinner, or if you have atrial fibrillation and you are on a blood thinner for that reason, the reason you have to stop those blood thinners is because during the surgery, you can sometimes have uncontrolled bleeding if you are on any kind of blood thinner. So you have to stop those blood thinners for a specific period of time, depending on what kind of blood thinner you're on. And then after the surgery, you have to stop these blood thinners for a certain period of time, because once you have a surgery, if you restart the anticoagulation immediately, you can actually bleed into the wound. So for example, if you have an ACDF or anterior cervical surgery, or you have a lumbar spine like a laminectomy or fusion surgery, you can develop a slow ooze and you can develop a hematoma. And in the cervical spine, that hematoma can choke the airway and it can sometimes kill patients. And in the lower back, the hematoma can sometimes push on the cauda equina. It can paralyze you. So for a certain amount of time after the surgery, you have to stop this anticoagulation. Now, for patients who have a high risk of blood clots, and for that reason they are on anticoagulation, a lot of times, if you have had multiple pulmonary embolism or multiple blood clots before surgery, the surgeon is going to be very leery because the surgeon definitely does not want you to get any of these complications, which can unfortunately sometimes end up in death. Another group of patients who unfortunately are unlikely to be offered surgery are those patients who have a history of a significant drug abuse. For example, if they were hooked on painkillers. Now, studies have shown that if you have a history of opioid dependency, and even if you manage to kick it, if you have a spine surgery where you have to take opioid medications for an extended periods of time afterwards, unfortunately, there's a significant risk that you're going to get hooked back on those medications. And opioid abuse is a terrible problem in our society, and it turns the lives of those people and their families and their friends completely upside down. And surgeons in general are very leery of pushing their patients into such a devastating problem after their surgery. And for that reason, if you do have a history of previous substance dependence, opioid dependence, you have to discuss this matter very clearly with your surgeon. You have to come up with a plan of how much opioids, how much painkillers you're going to take after surgery. You have to sign a drug contract, and you have to make sure that you look out for yourself, because your surgeon also wants you to have a very good and happy outcome after surgery. And another category of patients who are unlikely to be offered surgery with a high degree of probability is those patients who have a big surgical problem. For example, patients who have big scoliosis or big kyphosis or deformity of the spine, where the surgical time can be anywhere from 6 to 12 hours. That's a huge surgery. That's a huge recovery. There's a big chance that you will have some kind of a complication after surgery. So if you have a big surgical problem, if you need to be fused, for example, all the way from T2 down to the pelvis because you have a severe deformity of the spine, your surgeon will usually say, you know what, I'm not used to doing this kind of a surgery. And in that case, you can ask your surgeon, well, if you're not going to do the surgery, can you refer me to somebody else who does do this surgery on a regular basis? And in most cases, surgeons will be able to refer you to another surgeon who specializes in those very complex deformities. And I personally will sometimes refer those patients out to other surgeons who I know are subspecialists in that field of surgery. So I hope you found this video helpful. If you have any questions, please feel free to share in the comments below. Thank you for watching.